Assalamualaikum.
Assalamu alaikum, dear doctor.
Walaikum salam. How are you? Fine, inshallah?
Alhamdulillah, hope you're fine.
Excellent, excellent.
Alhamdulillah.
Can you see my screen?
Yes, we do.
Excellent. All right. That's very good. Yeah. Yeah, inshallah, it will be last session of this series. Of course, still lots of things are there to cover, but whatever we can do, we will try to do it today and see what we can do and then take it further from there.
Inshallah.
How are you?
Alhamdulillah, fine, very fine.
Excellent.
How are you? Like, you are in UK now, yeah?
Sorry, say again?
You are now in UK, yes?
Yeah. I'm in UK, yeah.
Did you receive the vaccine yet?
I had my second vaccine 2 days ago, and I'm having a little bit of, feeling a little bit of, aches and pains and some fever.
Yeah.
So yeah, it was AstraZeneca. So
good. Alhamdulillah.
Did you have it or not yet?
I'm still waiting in the waiting list.
All right.
Like you start in UK much earlier than us.
Yeah. You're right. I had my first one, I think in February. Yeah. Because the healthcare workers, all the healthcare professionals, they started bit earlier than everybody else. So that was the aim for them.
For us, the like staff of the hospital got it, but I'm part of the staff of the university, which we don't deal, like I don't deal directly with patients now.
All right, okay.
I'm mostly in academic field, so we are in the like third level. Like first, the medical staff who in touch with the patient, then the old age patient. So I'm not in the medical staff like first line. I'm not in the old age. So,
all right. So what is your specialty? What do you do there?
I'm the research center of diabetes.
Oh, diabetes. All right. Okay.
Diabetes research center. Yeah.
Excellent. Diabetes is a wonderful, very evolving specialty, isn't it?
Yeah.
And now basically it's overlapping with the cardiology. Lots of things are, like this newer agent, SGLT2 inhibitors and GLP-1 receptors agonists, they are basically very cardiac friendly, isn't it?
Yeah. Even we have many cases, like as you know, like diabetic patients, special type 2, mostly like they have already some kind like heart issues, like heart disease, hypertension.
Yeah, they are CVD equivalent, or considered to be well, they are diagnosed diabetes, they are already CVD equivalent, isn't it?
Yeah, exactly. So we have a lot of cases together, and we have many medications also work together. Now, I forget which medication we tested that it has also good impact on decreasing the like atherosclerosis. It is diabetic drug. We tested last year. I forget its name. So it has both like good impact on diabetes, blood sugar, I mean, and also the atherosclerosis. So delay that stenosis and yeah.
Yeah, they are all correlated, isn't it? They all yeah, of course. So
yeah,
like whenever you are ready, I will start, inshallah.
Inshallah. So our colleagues, as usual, enter one by one.
No, that's fine. Let them take their time. Of course, it's late for them as well. So yeah. So
in Iraq, they just today started with the AstraZeneca vaccine.
Sorry, I could not hear you nicely. Say again.
In Iraq, just today they started with AstraZeneca vaccine.
All right. Okay. Oh, that's a very good news, actually. Is it same like they are looking after the healthcare professional first, or the general population?
They opened also for general population because they started 2 weeks ago, I think, with Sinopharm vaccine.
Oh, the Chinese one. All right. Okay.
Yeah, from China. So this is the second like vaccination.
All right.
And unfortunately, not all the medical staff registering for the vaccine. So now they open it even for non like medics.
All right. Okay.
Yeah, but there's people who taking now. Alhamdulillah.
Yeah, inshallah, over the course of time, the awareness will be more and perhaps more people will register for it, hopefully.
Inshallah.
In Pakistan, it is same. Even the medics, the clinician, the doctors who are working in hospital, they are very reluctant to take the vaccines. I don't know why, but slowly and gradually the take is better. They are getting, I think they are taking their own time to see how the things are evolving. And not sure, but of course in Pakistan also same. They started with the Sinopharm and now they are having the AstraZeneca. There is no Pfizer or Moderna there. So these are the two vaccines. They also have it there.
It's because of the lot of fake news, like.
All right. Okay. Yeah,
Yeah.
you're right. Yeah, there is a lot of disinformation on this social media, unfortunately. But I think this is important for everybody to have it, in order to
Yeah.
fight the virus and, of course, develop the herd immunity over the course of time for the rest of the world. So these are important things. But let's see. So should we start now? Do you think?
Maybe in 2 minutes.
Yeah, sure.
Yeah, inshallah.
Yeah, I'm okay with. I don't have any problem because the thing is, uh, I may be needing. I need to show at least 100, almost 100 slides. So I just need to, it need to be quick basically. That is the only thing, because ECG is a very, very vast subject, and even 3 years, 4 hours or 4.5 hours is not enough. But I tried my level best to cover as much as I can, but maybe something may be missing. So I will try to cover in between, even if I don't have these slides for that particular clinical situation. So I will try explain in between.
Inshallah. Thank you.
So whenever you give me the green signal, I will just start.
Sorry.
Whenever you give me the green signal, we will start.
Yeah. So, Bismillah, Dr. Ali.
Yeah, so nice of it. Thank you very much. Bismillahirrahmanirrahim. Assalamu alaikum to all of you, and welcome to this last session of the ECG series. We have tried to cover most of the topics during past 2 sessions, and now mainly the heart blocks and coronary issues are left, and perhaps I will try to show you some more interesting ECGs in the end, if the time allows us. So let's start with the heart block. So we have discussed the heart rhythms and everything, and we have discussed the electrical channels and flow of current into the heart conducting tissues. So now, if we talk about the heart block, this is all because of the interruption of the electrical signal which travels from the atrium into the ventricle, and usually it is around the AV node. So if we talk about there are 3 types of heart blocks. One is called first degree heart block, then second degree heart block, which is divided into two parts. And we will discuss that when we show the slides. And the third is complete heart block or third degree heart block. So first degree heart block is basically prolongation of the PR interval more than 5 small square or 0.2 second. Usually it is because of the ischemic heart disease or rheumatic heart disease as well. It could be because of the toxicity to various medication, including digoxin and calcium channel blockers, as well as beta blockers. It could be because of the electrolyte imbalance, myocarditis, or pericarditis, as well as due to various reasons for the increased vagal tone. So that we have discussed. So if you have a look on this heart rhythm, this is just the rhythm strip, not the full ECG. As we discussed, the normal PR interval is within the one large square, which is 0.2 second or 5 small squares. And if you see here, if you take it as a baseline, then the PR interval, which is the start from the P wave till the start of the QRS complex, is almost 1, 5, 6, almost 9 small squares. So this is prolongation of the PR interval. And this is basically an example of the first degree heart block. Right. So this is the rhythm which we have discussed. The PR interval is fixed and it is more than 0.2 second. And this is first degree heart block. And this is an example of the ECG. So this is 12 lead ECG. And the best strip or best lead to comment on the rhythm is the lead 2, which is because the lead 2 is facing the SA node and AV node better than any other lead. And if you see here, this is the rhythm strip. And this is again almost two large squares, which may be almost 9 small, so 0.182 second. And this is first degree heart block. The 1 and AVF, if you talk about the double thumb rule of the axis deviation, which we discussed earlier, it is left axis deviation. And if we see anterior chest leads, there is normal progression of the PR interval. So basically this is first degree heart block with almost no acute changes in the ECG except for the first degree heart block. Right. So if we talk about the second degree heart block, it is divided into Morbus type 1 or Venki-Bach phenomena. Venki-Bach basically is a French term, and it was a French cardiologist who picked up this phenomena many years ago before the invention of the ECG machines, and he just felt it by observing by feeling the pulse and looking into the jugular veins wave pattern. So this is Morbus type 1 or Venki-Bach phenomena. Usually there is progressive prolongation of the PR interval until one P wave is not conducted or there's a drop of the one beat. Usually, most commonly, it is because of the inferior wall myocardial infarction, and over the course of time, then slowly it recovers to the normal sinus rhythm. It could be in the trained athletes, and it could be because of the drugs, which we have discussed on many occasions. So if you have a look here, this is the Morbus type 1 Venki-Bach phenomena. And if we start from this wave, this is the PR interval is prolonged, and the second wave, there is progressive prolongation. And the third beat, again, there's a progressive prolongation of the PR interval. And this P wave is there, but there is no QRS complex. So this is basically, here the blockage is there. And this is Venki-Bach phenomena or Morbus type 1 second degree heart block. Right, this is a simple rhythm strip. And if we start from the first QRS complex, PR interval is which is the normal limit. The second base, second QRS, second complex is showing PR interval is prolonged than the normal. which is more prolonged, and the third, and then there is a non-conduction of the P wave. So this is Morbus type 1. Right, so this is another rhythm strip. And again, PR interval is progressively prolonged until the fourth P wave is not conducted, and there is first degree hard block. Right, this is another example, progressive prolongation of the PR interval, and there is no P wave. Sorry, no, there is drop of the missed speeds. And this is the another one, PR interval is prolonged from the beginning, and there's one beat which is not conducted, and it is same thing in the third strip as well. Right, so this is again, if we have a look on the rhythm strip, this is the first QRS complex, PR interval is normal, then there's a prolongation of the PR interval, and the third beat is missing. If you have a look on the ECG, grossly, so double rule phenomena, if you have a look in the lead 1 and lead AVF, so the double thumb rule, it is normal ECG, sorry, normal QRS, I'm sorry, this is normal axis. And if you have a look at the anterior chest leads, there is normal prolongation of the PR interval in the chest leads, and this is practically normal ECG except for the first degree, sorry, the second degree Morbus type 1 heart block. So if we talk about the Morbus type 2, here there is no prolongation of the PR interval. The PR intervals are fixed, and usually it can be varied blocks, and one P wave is not followed by the QRS complex. It is usually because of the degenerative process in the conducting tissue, which can lead to the fibrosis of the AV node or maybe bundle of His, causing second degree AV block. It can be associated with the anteroseptal or massive acute myocardial infarction, and it may progress to the complete heart block. Usually that's what happens. Right, so if you have a look here, this is the graphical representation. So these are all P waves which they have marked. And if you see, PR interval is regular, but after every couple of QRS complex, there is one misspeed. If you have a look, this is the P wave followed by QRS complex, P wave followed by QRS complex, and PR interval is normal and fixed, and the third P wave is not conducted. So this is basically 3:2 AV block. 3 means there are 3 P waves, while QRS complexes are only 2. So this is 3:2 AV block. If you progress more into the same rhythm strip, you will see very varied number of blocks. For example, here there are 2 P waves and 1 QRS complex, and PR interval is normal. So this is 2:1 AV block, which is Morbus type 2. And as I mentioned, this is because of the degeneration and fibrosis of the AV node and associated tissues. Right, so this is again same thing. This is P wave, PR interval is normal, QRS complex, and this second P wave is not conducted. So this is 2:1 block. Same thing here in the second QRS complex, there are 2 P waves, and the second P wave is not conducted, and so on. And this is the graphical presentation of the same thing. Right. So anybody want to comment on this rhythm strip? Anybody? Just be bold and just show your confidence and tell me what is going on here, if anybody want to. I will wait 1 minute, otherwise I will just discuss myself. Okay, so this is the first QRS complex. The P wave is normal shape, PR interval is normal, followed by QRS complex, and then next P wave is prolonged, followed by QRS complex. So this is progressive prolongation of the QRS complex over the past next 3 QRS complexes, and the fifth P wave is not conducted. So this is Venkiboff or Modbus type 1 AV heart block.
Plus there is like ST like depression, right?
ST depression, if you, it is, yeah, you are right. There is a this ST depression of almost, yeah, this is very intelligent observation. This is an ST segment depression of almost two small squares of 2 millimeters, but the ST segment is upsloping and QR and the T wave is upright. So it's not showing any sign of any ischemia. If the T wave would have been inverted, then it could be a non-ST segment elevation MI or an ST MI as well. But of course, without doing the troponin test, you simply cannot comment. But there is slight QRS, slight depression of the ST segment. I 100% agree with you. And this is Venkiboff phenomena or type 1 Morbus type 1. You are very right. Thank you for that. So this is again, yeah, this is the, if you have a look on the rhythm strip first. So because, yeah, this is the P wave followed by QRS complex and the PR interval is normal. The second wave is same, and then this P wave is not conducted. Basically, this is 3:1 AV block. If you have a look on the ECG grossly, the axis is normal. There is progressive prolongation of, there's progressive normal progression of the QRS complex. So this is normal ECG with second degree AV block, and it is not associated with any ischemic changes. So most probably it is just idiopathic, which is the degeneration and fibrosis of the AV node. Right, so this is another ECG, and we have a look in the, there is no rhythm strip, but rhythm strip they have used is V1 here. And this is the P wave, which is slightly deformed, but within the normal range, followed by QRS complex. Then this is T wave, and this P wave is not conducted. So this is 2:1 block. Here it is 3:2 block. So this is Morbus type 2 AV block. And if you have a look in the limb leads 1 and AVF by rule of double thumb, this is left axis deviation. And if you have a look in the anterior chest lead in the V1, there is tiny r followed by S, then R, this is SRS phenomena, and this is prolonged QRS complex. So this is right bundle branch block. And we have discussed before as well about the bifascicular block. So if, just to refresh, if the current starts in the SA node, then reaches to AV node, and then there are left bundle and right bundle. When we talk about the fascicular blocks, we consider right bundle as a one fascicle and left bundle because it is subdivided into left anterior fascicle and left posterior fascicle. So these are the two fascicle. So basically in the ventricle, the conduction is through the three fascicles of the conducting tissue, the right bundle branch and the left bundle, and two branches of the left, or two fascicles of the left bundle. So when we talk about the right bundle branch block, basically the one of the fascicle in the ventricle is already blocked. So the current is only flowing through the left bundle. And if the right bundle branch is associated with axis deviation, then they say there is maybe blockage of, there is maybe hemi blockage of one of the fascicles of the left bundle. So if it is left bundle branch, if it is left axis deviation, which this ECG is showing, then this is left anterior hemi block. So right bundle branch block plus left anterior hemi block indicated by the left axis deviation is bifascicular block. Similarly, if there is right bundle branch block, associated with right axis deviation, then it will be right bundle branch block associated with the left posterior AME block, again indicating bifascicular block. And if we talk about trifascicular block, which is a bit of misnomer because we talked about ventricles having electrical current through the three fascicles. But when they talk about trifascicular block, they include first degree heart block along with bifascicular block. So it could be right bundle branch block associated with left axis deviation or right axis deviation and first degree heart block. So this is basically trifascicular block. I have not included any specific slide for that, but I thought I will just mention here. If any question regarding that, I can just clarify. Otherwise, we move on. Is that okay?
Yes. Oh.
Excellent. Okay, so I will proceed. Right. So again, this is the rhythm strip, and so first three complexes PR interval is fixed and normal, and then followed by a misspeak, and similarly same thing. So it is not fitting into the AB block. Basically, if you see after the third QRS complex, there is no P wave, and there's a prolonged pause followed by a QRS complex, which is same as previous one, but it is bit complicated. It is bit bizarre shape. So most likely it is sinus arrest when SA node was unable to conduct any beat, create any beat, and then it is followed by the compensatory pause and this is the escape rhythm, most likely. Of course, you need to have more information in front of you, but this is the likely information in front of me. So if you have a look on the limb leads, when an AVF by rule of thumb is normal axis and PR interval, there is normal progression of the R wave in the anterior chest leads, and except for this escape rhythm followed by a escape rhythm is there, and then the sinus is regenerating its activity and creating the normal flow of current. Right, so let's talk about the third degree heart block. Here, basically, the AV node is completely blocked and it's not allowing any current from the atrium to conduct to the ventricle. So atrium will be creating the SA node will be creating the P wave, which will be which will be firing at their own rate, which is anything between 60 to 100, and because it's not conducted to the ventricle, so ventricle activity will be from the ventricle, one of the ventricle conducting tissues, and because the conduction velocity in the conductive tissue of the ventricle is slightly slow, the QRS complex will be prolonged and bizarre. And the heart rate may be anything between 20 to 40 beats per minute. So if you see here, this is the P, 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 P. So you can guess that PP interval is normal and QRS or R wave interval is again normal. P waves are firing at a higher rate, maybe around 70 beats per minute, while the ventricular rhythm is anything between 1, 2, 3, 4, 5, 6, 7, 8. So almost 20, 25 beats per minute. So this is basically third degree heart block. So same explanation which I already explained to you. The P waves are completely blocked in the AV junction. The QRS complex originate independently from below the junction, and that's why they are bizarre, broad complex, and at a slower rate. Right. So this is because of the complete failure of the conduction in the AV node, and they are just firing independently of each other, which we have discussed before. And ventricles, their intrinsic pacemaker kicks in anything between 20 to 40 beats per minute. That's why they are slow. And yeah, so they have just explained why it is broad and bizarre. Right, so this is same thing. If you have a look here, this is the ventricular beat followed, and you can see the PP interval. They are firing at a regular interval, and P wave, as explained, they are looking same shape and conformity, and QRS complexes are very wide and bizarre, and heart rate is very, very slow. So this is third-degree heart block. Another example, PP interval is perfectly regular. The QRS or RR interval is again regular, and the rhythm is third-degree heart block or complete heart block. And it's again same here. And if we just have a look on the ECG globally, so 1 and AVF, so this is left axis deviation. And if we see the anterior chest lead, there is RSR phenomena, which is right axis deviation, right bundle branch block. Sorry, today I'm not well because of my vaccine reaction. So if I say something little bit odd, just forgive me about that. So because of the RSR and right bundle branch block, cannot comment on the anterior chest lead, but they look fine except for the right bundle branch block. So they fit into the definition of the bifascicular block if there was not complete heart block. So this is just to see that if there was normal sinus rhythm with right bundle branch block in the anterior chest lead and left axis deviation, it would have been bifascicular block. Right, so this is another example of third-degree heart block. The heart rate is quite slow. P waves are beating independent of the QRS complexes. And this is again third-degree heart block. It is AVF, 1, 2, 3. This is AVF, this is normal axis, and the right bundle branch block is again there. And this is third-degree heart block, no acute ischemic changes. Right, so this is a very beautiful ECG. Again, complete heart block, axis is left, and this is, there's no prolongation of the PR, of the R in the anterior chest leads. So most like this patient might have had anteroseptal or anterior myocardial infarction before. That's why he may be having this complete heart block. But you need more information about that. Right, so this is again, PP intervals are normal and QRS complexes are again, beating regularly on their own pace. The axis is normal, and in the anterior chest leads V1, V2, V3. If you have a look, there are some T wave inversion in 2, 3 AVF, and as well as anterior chest lead. And most likely it could be some sort of non-ST segment elevation MI, but of course you need troponin and details of the comorbidity of the patient and presentation of the patient. So this is for practical purposes, this is complete heart block, and there are some T wave inversion. Most likely this is ischemic changes. Right, anybody want to comment on this ECG? I will be very happy if anybody want to comment, just a single word.
So I see ST elevation.
Excellent, all right, yeah, sure.
Wide QRS.
Excellent.
Irregular rhythm.
Yeah, rhythm is irregular. You are very right. Yeah, perfectly normal. Yeah, it's irregular rhythm. Yeah.
And there is, I think, pacemaker, not pacemaker.
Very good. Yeah, that's what I wanted to point out. Yeah, excellent.
Yes, step.
Yeah.
How call it pulse maker. We call it in German Schrittmacher. So I don't know. I forget the English name.
So, yeah, this is called pacemaker spike.
Pacemaker, yeah, pacemaker.
Pacemaker spike.
Like, yeah,
If you see, every QRS complex is preceded by a pacemaker spice,
yeah.
and because the conduction is not sinus, so that's why the complexes are broad and bizarre. But this is the pacemaker rhythm, and I just wanted to see to show this because just to have a good mental picture of how the pacemaker ECG can be recorded. So this is basically just pacemaker rhythm. Right. So this is another ECG, and yeah, if you see again, if you have a look on the lead 2, you can see pacemaker spikes are there, but if you see the pacemaker spikes are not followed, not associated, not there in all the QRS complexes. For example, if we in the lead 2, if we have a look, there is P wave and there is QRS complex. Then second beat is having the pacemaker spike. The third wave again pacemaker spike. The fifth one there is P wave. So it is indicating that the pacemaker is basically, it is called on-demand pacemaker. Normally, most of the pacemakers are set at a heart rate of 60 beats per minute. If the intrinsic heart rate from the SA node is less than 60, then pacemaker normally takes over. So here the heart rate would have been normal. That's why the pacemaker activity is not there. And when the heart rate gets slow, after if it is below 60 beats per minute, then pacemaker takes over. So this is just to show how the pacemaker normally work. Right. So any comment, any question on heart blocks before we proceed to the ECG depicting some acute ischemic changes, and of course something else as well. Any question on heart blocks?
Well, guys, if you just listen, you will may gain something, but if you interact, you will learn much more.
Yeah, I
So,
will be very happy to clarify if there is anything they want to.
and don't be embarrassed that your English is not perfect.
No, I don't mind that. Yeah.
Even the British people don't speak like perfect English.
You're right. Okay, so I will proceed further. So now we are going to talk about different ECGs of various ischemic changes and acute coronary syndromes. So this is, we have discussed before as well. So we are talking about which uh, coronary artery is blocked in case of regional myocardial infarction. So if it is inferior wall, it will be right coronary artery. If it is anterior septal, it will be left anterior descending or one of its major branches. If it is anterior lateral, like from V1 to up to V6, sorry, anterior lateral mean lead V4, V5 and V6, and maybe one and AVL as well. So one AVL, V5 and V6 is called lateral MI, and this is the usually circumflex artery. And posterior myocardial infarction, which is usually difficult to pick up on ECGs, again because of the right right coronary artery. But at times there can be the right coronary artery can be dominant, then it can supply to the lateral and posterior wall as well. So in this situation, usually if there's any myocardial infarction, it will be having regional ECG changes in the inferior lateral leads as well as posterior leads. So if inferior leads are usually 2, 3 AVF, anterior septal leads are V1, V2 up to V4, and anterolateral is 1 AVL and V4, it is wrong with V4 to V6. Right. So if this is just a nomenclature of how the patient presents, if patient having some comorbidities and presented with typical anginal or ischemic type chest pain, then patient need to be admitted for observation, and of course, without seeing the ECG or any biochemistry, you can say that the patient may be suffering from acute coronary syndrome, and you do the ECG. Of course, you have to have the IV access prior to that, and airway breathing and circulation, which is the nomenclature of any patient presenting to the emergency department. So you have done the ECG. ECG is showing ST segment elevation. Then it could be it is ST segment elevation myocardial infarction. If there are STT non-specific changes and you are not sure of any definite ischemic changes, then you have to do the troponin test. If it is high, then it is non-ST segment elevation MI. And if it is normal, then it could be unstable angina, unless proven to be prove otherwise. Yeah, sure. So yeah, so we have discussed that myocardial infarction can be ST segment elevation or non-ST segment elevation. So when we talk about the ST segment elevation, we discussed that either PR segment or the ST segment, they are the baseline, and you just compare the ST segment depression or elevation from the baseline. So if there is no ST segment elevation, we cannot comment. So if we have a look on the PR interval and PR segment, this is the baseline, is a tiny Q, ST R wave, then ST segment is basically quite elevated. So if you don't have troponin test done, even then based on this ECG and typical symptoms of the patient, you can just say confidently that this is ST segment elevation, myocardial infarction, and you have to treat accordingly. And of course, this we have mentioned this, the Q wave is in evolution. Right. Of course, the second one is non-ST segment elevation MI or non-Q wave MI. So so the classical symptoms we have, you are aware, there is no need for me to repeat that. And of course, signs of acute MI is usually associated cardiac enzymes and markers, and physical signs, patient may be hemodynamically stable, unstable, and maybe saturation may be dropping. So you have to just correlate everything into, so good clinical history, physical examination, and the ECG and the biochemical lab support help you reaching to the diagnosis of myocardial infarction. Right, so in non-ST segment elevation MI, the typical picture of the myocardial infarction may not be there. There may not be ST segment elevation, there may not be ST segment depression, and there may not be any Q waves. So only clue may be sometime T wave or ST segment changes. Right, so if we discussed before, this is the baseline, and if we compare the ST segment to the baseline, the ST segment is definitely depressed, maybe almost 3 to 4 small squares. And unless you have, while you are waiting to have the troponin test done, you can say that this is non-ST segment elevation MI, but the final diagnosis will be on the basis of troponin test, because ECG is having some changes, but not very suggestive of myocardial infarction. Right, so in ST segment, so this is again the same thing. This is the baseline, this is the normal ECG, and PR segment and ST segment are on the same baseline. In the ST segment elevation MI, you can see the ST segment is elevated high up, while in case of non-ST segment elevation MI, either the ST segment is depressed or there may be only T wave inversion. And of course, in case of non-ST segment elevation MI, the diagnosis is basically requiring confirmatory troponin test. Right. So in case of non-ST segment elevation MI, basically the injury is only subendocardial, not through and through. So this is earlier it used to be, we used to call it subendocardial myocardial infarction as well, but over the course of time the term is changed and they started calling it non-ST segment elevation MI. So basically in the non-ST segment elevation MI, the myocardial damage is only subendocardial. While in case of ST segment elevation MI, it is through and through transmural from epicardium up to the myocardium. And of course, over the course of time, it develops the fibrous tissue. While in case of non-ST segment elevation MI, because the heart damage is only partial and the remaining myocardium is very thin, at time there can be chances of patient having myocardial rupture because of another incident. So these patients who have non-ST segment elevation MI, they need to be treated very aggressively by having the primary PCI or cardiac or the stenting of the corresponding coronary artery. Right, so various examples of ECG showing ischemic changes. So if you have a look in this ECG, lead 1, there is this is the baseline. PR segment and ST segment is depressed. Lead 2, ST segment is depressed. Lead 3, very bizarre sort of QRS complex, so difficult to comment on. But AVF, if you see there's ST segment depression, and AVR is, of course, I mentioned to you guys before that AVR is cavity lead and it need to be usually negative, but here ST segment is again elevated. In lead AVL, ST segment and T wave inversion is there. In anterior chest leads, if you have a look, V1, V2, V3, there are ST segment depression in almost all the anterolateral chest leads from one AVL anterior chest lead and all of the lateral chest leads. So most likely it is non-ST segment elevation MI, including anterior leads and lateral leads. Most likely it is dominant right coronary artery causing non-ST segment elevation MI. Right, this is an example of the ST segment elevation MI. If you see in the limb leads, all the leads are not showing any sign of ST segment depression or elevation, while in the anterior chest lead, the ST segment elevation starts in the lead V1, and then lead 2, lead 3, and lead 4. It is quite easily identified by lead 5 and 6. There is hardly any changes. So basically, this is anteroseptal myocardial infarction, which is ST segment elevation. If you see in the lead 2 and 3, you can see development of the Q wave. So Q wave is already started developing, and over the course of time, it will be more deep and more wider. So this is ST segment elevation MI of the anteroseptal region of the heart. Right, this is another ECG, and here you can see lead if you have a look on the limb leads, lead 1 ST segment depression with T wave inversion, lead 2, lead 3, and lead AVF. There are ST segment elevation with the evolution of the Q waves in lead 1 and in lead 3 and lead AVF, while in one AVL ST segment is depressed and the T wave is inverted. And similarly, in the anterior chest leads, almost same thing. Basically, this is ST segment elevation MI of the inferior region of the heart, shown in lead 2, 3 AVF. In lead 2, the ST segment elevation is minor, but over the course of time, it will evolve. And there's a term called reciprocal changes. If there's a ST segment elevation MI, in the opposite leads, usually ST segment is shown to be slightly depressed. So these are called reciprocal changes, and basically depicts that these this region is also under the danger of having some blockage of the arteries, but not full-blown myocardial infarction. And basically, this is inferior wall myocardial infarction, ST segment elevation, MI. And if you see the rhythm strip, this P wave, and this P wave is not conducted. This is P wave. This is prolongation of the PR interval, and then one is, so this is basically Wenckebach phenomena, or Morbus type 1 AV block is also there, which is very characteristic of inferior wall MI. Right, this is another ECG, and here in this ECG, what it is showing, if we have a look in the lead 2, the rhythm is P wave is there, PR interval is normal, so rhythm is normal sinus rhythm. This, if we have a look in the limb leads, lead 2, 3, and AVF ST segment is elevated, while lead V1, V2, and lateral leads, the ST segment is depressed. So again, acute inferior wall myocardial infarction with reciprocal changes in the anterior leads. So this is most likely ST segment elevation myocardial infarction. Yeah, this is very beautiful ECG. If you have a look, you can just see and you can comment that ST segment is very, very elevated, and T wave are very, very hyperacute or very, very tall. Sometimes we call it hyperacute T wave, or sometimes it is called tenting of the T wave, but I will show you more ECG if I get time to show you. So in the limb leads, basically the axis is normal and most of the leads are within acceptable range, not showing any gross changes in the limb leads. And in the anterior chest leads, V1 is normal. From V2, V3, V4, V5 up to V6, the ST segment is elevated, and the Q wave is still not started developing. So this is acute ST segment elevation, MI of the anterolateral region from anterior leads up to the lateral leads. So it's a massive MI, and troponin will be very, very grossly high. Right, this is another ECG, and in the limb leads, there are T wave inversion in lead 3 and AVF. In the anterior chest leads, again ST segment elevation in the lead 2, 3, and 4. So this is basically anteroseptal myocardial infarction, and because this is ST segment elevation, so of course it is transmural, and this is not non-ST segment elevation MI. You can see the ST segments are grossly elevated. Right, this is another beautiful example of hyperacute T waves, and we also call them tenting of the T waves, and this is ST segment elevation MI of the anterior chest leads, and there are reciprocal changes in the lead 3 and AVF. So you can easily identify the ST segment elevation myocardial infarction in this ECG. Right, this is another ECG, and again, if you have a look, there are ST segment elevation in lead 2, 3, and AVF, and the reciprocal changes in the lead AVL only, yeah. And yeah, this is very interesting ECG. If you have a look in the anterior chest leads, lead V1, V2, V3 up to V6, there is some Q waves from lead 2. There are in the lead 1, lead V1, if you see, there is a tiny R wave followed by deep S and then normal ST segment elevation. I'm sorry, normal ST segment. Lead 2, lead 3, there is no R wave. There is deep S wave followed by normal looking ST segment and upright T wave. It is up to lead 6. So patient has old anterior wall ST segment elevation myocardial infarction, and that the new changes are in the inferior leads, indicating that now the patient is having inferior wall myocardial infarction. So this patient need to be very carefully treated because he already had old and anti-wall myocardial infarction. Now this is a new inferior wall myocardial infarction. Again, hyperacute changes in the lead 2, 3, and AVF, and reciprocal changes in the anterior and lateral chest leads. This is again inferior wall myocardial infarction, which is ST segment elevated. Right. Now, this time, if you have a look in the anterior chest leads, ST segment elevation, and these QRS complexes are showing evolution of the Q wave, mainly in the lead 2 and 3, but ST segment is also elevated in the lead 4. So most likely it is going to be a ST segment elevation myocardial infarction of the anteroseptal leads, and the rhythm is normal. The axis is most likely left axis, but it will evolve over the course of few days. Right, so this is, yeah, so this is, if you have a look in the lead 2, 3 AVF, the inferior leads, in lead 2, ST segment is borderline elevated. In lead 3 and AVF, it is grossly elevated ST segment with already evolved Q wave. So this is ST segment elevation myocardial infarction of the inferior chest, inferior wall, and there are reciprocal changes in the opposite leads. And because this is an inferior wall myocardial infarction, we said that there can be AV nodal blockage. So if you can see, there is this is basically look like, yeah, this is again Venn-Bock phenomena, and few leads are not, this is P wave here, this is PR interval prolong, and the third beat is missing. So this is Venn-Bock phenomena with acute inferior wall myocardial infarction. And in this ECG, this is again a different one, ST segment elevation in the lead 2, 3, lead V1, V2, V3, V4, V5. So this is anterior wall ST segment elevated myocardial infarction, and there is T wave inversion in the lead 3 and AVF. This is another hyperacute ST segment elevation changes in the anterior chest leads, almost from V1 up to V6, and rhythm is sinus. The axis is still normal. So this is the ST segment elevation myocardial infarction involving the whole anterior wall. And of course, you need to do the troponin. And because this patient is having massive MI, so maybe hemodynamically stable, so you need to look after this patient very carefully. This is very beautiful ECG again. And from lead 1, AVL, V1, V2, V3, V4, V5, V6, all the leads are hyperacute ST segment elevation myocardial infarction, and there is no evolution of the Q wave yet, and you can see beautiful reciprocal changes in the lead 3 and of course AVF. So this is massive MI including the anterior wall as well as the lateral wall. And again, patient will be quite unwell, needing hemodynamic support. And of course, we need to be taken to the cath lab depending on how the patient is presenting. This another ECG, tall tenting T, P, T waves in anterior chest leads and reciprocal changes in the lead 3 and AVF, indicating that this is ST segment elevation myocardial infarction of the anterior region. I'm showing all these ECG because you can compare, see, and how the patient can present, and you can pick up the ECGs based on how the changes are. This is again different ECG showing ST segment elevation in lead 2, 3, and AVF. And in lead 2, you can see tiny Q wave is started developing, while in 3 and AVF, there are good Q waves already formed. And you can see ST segment depression in the lead 1 and AVL, which is the reciprocal changes. And if you have a look in the anterior chest leads, there are Q waves in lead 2, 3, 4, 5, and even 6. So patient is already had whole myocardial infarction of the whole of the anterior wall, and now this is a new myocardial infarction of the inferior leads. So this patient is must be in heart failure or something from even prior to having this new cardiac insult. Right, this is another ECG which, just a graph of showing how you are going to differentiate between the non-ST segment elevation MI and ST segment elevation myocardial infarctions. So this is a patient who is 47 years old and presented with the chest pain. You can see the ST segment elevation in the lead 2, 3, and AVF, and there are T wave inversions in the lead AVL only, which is borderline reciprocal changes. If you have a look on the lead 2, the rhythm is normal sinus rhythm. Heart rate is bradycardic, which could be because of the inferior wall, and at time the AV node can be involved. That's why they can present with the sinus bradycardia as well. Right. So posterior wall myocardiation we discussed before as well. It is very difficult to pick up on the ECG. Normally, what you need to do is you need to have a look on the ECG. If there are some R wave changes in the anterior chest lead, then they recommend just hold the ECG upside down and face it to the mirror, and you can say the mirror is depicting ST segment elevation in the lead V1, V2, because there are you are not recording basically you are not putting any leads on the posterior leads, and you are just putting on the anterior chest. That's why you have to just get the indirect evidence from the posterior wall, which is through the lead V1 and V2, and which will be opposite the normal R waves in the lead V1, V2 usually. Right. So if I show you previous ECG, just to compare, this is the normal V1, V2. There is tiny R wave in lead 1, and then there is the R wave is slightly more prominent, and gradually it progresses, and in the lead 5, 6, they are basically only tall R waves. So in this ECG, if you see, instead of tiny R wave, the R waves are very, very well developed and prominent, and there are T wave inversions, and lead 2 again T wave inversion, and some evidence of ST segment depression. If you see, this is the PR segment, and there's some indication of ST segment depression. So if you hold it upright, upside down, So you just turn it over and face and show it on, see it through the mirror, and you will see in the mirror that there will be Q wave. This R wave will you will see as Q wave in the mirror with this ST segment elevation. So basically that will depict posterior wall MI. ST segment, of course, you need to do the troponin, and you can't see any changes in the any further changes in the anterior chest leads. And there are some T wave inversions in lead 3, which is reciprocal changes, and otherwise rest of the ECG is normal. So it needs very high suspicion on index, and you need to know how the R wave is progressing in the anterior chest leads. Then only you can pick up the posterior wall myocardial infarction. And of course, this is very necessary that you hold the ECG upside down and then see it through the mirror. Right. So the changes are in the lateral leads, lead 1, AVL, and lead 4, 5, and 6, and even V2 and V3. So this is basically anterolateral left anterolateral non-ST segment elevation myocardial infarction, and basically it is indicating subendocardial damage to the myocardium. And of course, you need the troponin test to confirm that this is myocardial infarction, not the unstable angina. Right, this is another ECG. The changes are mainly in the lead 2, 3 AVF, and then lead 5 and lead 6. This is all T-wave inversions involving lead 2, 3 AVF and lead 5 and 6, indicating that the involvement is inferior wall as well as the lateral wall. So most likely the right coronary artery is dominant and even supply the lateral wall of the heart instead of circumflex artery. So most likely the culprit artery is right coronary, and of course you are going to do the troponin test, and patient will be needing PCI, primary PCI. Right. So this is very beautiful T-wave invergence in the lead V1, V2, V3, all the anterior chest leads from V1 up to V6. And of course, there are T-wave inversion in the lead 1 and AVL as well. And most likely this is ST segment elevation MI of the anterolateral heart. You need troponin test to confirm. Right, so this is another ECG, and again the T-wave inversions are in the from lead 3, 4, 5, 6, and lead 1 and AVL, while the inferior wall changes are not there. So this is non-ST segment elevation and myocardial infarction of the lateral chest leads, and you need confirmation by the troponin test. The rhythm is normal and normal sinus rhythm and regular. Right, so we have finished the major portions, and I'm just going to show some ECGs. If you guys are happy, we can just continue for another 10-15 minutes, showing you some different ECG presentations. If all the colleagues are happy, is that okay? Should I continue, or we just finish it off?
Go on, please.
Okay, thank you. So yeah, you have seen that already. We have discussed. So this is a normal sinus rhythm. The QRS complexes are preceded by the P. This is broad bizarre QRS complex. And this is a ventricular ectopic or premature ventricular contraction, just out of interest here. So if you see here, in the first one, there was only one P. And of course, you can just pick it up without any problem. In this rhythm strip, you can see this is the premature QRS complex or PVC. This is and this is another QRS complex, which is broad and bizarre. This is a, PVC, and this is second PVC, but both are different in conformation. So this is called multifocal or multiform PVCs. In one rhythm strip, you are seeing multiple PVCs, indicating that the ventricle conducting tissues are firing at different foci, creating multifocal or multiform PVCs. It means the ventricle myocardium is very, very irritable and something nasty is going on. So this is the ECG showing multiform ECG, sorry, multiform premature ventricular contractions. This is very good ECG. If you see the rhythm strip, this is a normal P wave and QRS complex followed by one broad bizarre complex, which is the PVC. So one normal QRS complex is followed by a premature ventricular contraction. So this is called bigeminy. One normal complex is followed by a premature ventricular contraction. So this is bigeminy. If every second QRS complex is followed by a PVC, which will be the third wave, so it is called trigeminy, and so on. So bigeminy, trigeminy, tetrageminy. So this is the PVCs, and again, if you see, this is normal looking ECG, except for the PVCs, which is totally different. So this is a normal QRS complex. This is the PVC. Then this is normal QRS complex followed by PVC. This is again bigeminy PVCs. Yeah. So anybody can pick it up what it is. This is basically a tent, and this is various types of the tents. And basically why I have put it here is just to show what is the tenting of the T wave, which we have discussed before, anterior chest. So this is the tenting of the T waves. And in this particular ECG, if you see, there is no ST segment elevation. There's normal progression of the R wave in the normal chest leads, and there's a tenting of the T wave. So most likely it is because of some other changes, not the ischemic changes. And usually the commonest cause is hyperkalemia, where you find this tenting of the T wave. But of course, I have shown you many ECGs indicating that it is associated with the ST segment elevation and indicating hyperacute T waves or ischemic changes. This is another example. And yeah, this is just, so this is irregular rhythm, and this is sinus arrhythmia basically, but there are T wave inversions as well. But no, it's not sinus arrhythmia. So this is basically, it's atrial fibrillation, because if you see there is no specific P waves there, this is atrial fibrillation. Yeah, this is beautiful. All of you may be aware that in olden days, we used to use only digitalis to control the ventricular rate of the atrial fibrillation. And digitalis, when patient is on digoxin for long period of time, there can be some ST segment changes in the ECG, and which is called the digitalis effect. It is also called reverse tick sign. If you see, this is tick, this is reverse tick. So this is basically not the digoxin toxicity, it is just effect of digoxin on the ST segment of the ECG. And this is a very beautiful ECG depicting a mustaches of a of an area of a country in South America, which is called El Salvador. So people in the El Salvador, they keep mustaches like a reverse tick. So sometimes it is called El Salvador mustache sign, reverse tick sign, or digitalis effect. So you may find these type of ECG changes in patients who are having AF and are on digoxin. So this is called digitalis effect. The same thing, rivastic sign or El Salvador Mostes sign, and the rhythm in lead 2 is atrial fibrillation. Right, so this is lead V6. There is no P wave. This is most likely the junctional. No, this is the ST. This is again rivastic sign, and this is most likely atrial fibrillation. Right. So this is again rivastic sign, and this is the digoxin effect in a rhythm, which is atrial fibrillation. This is another El Salvador Mostes sign. In the lateral chest lead, you can see. Right. So this is, yeah, this is, if you have a look here, these are lead, anterior chest lead. You can see ST segment elevation in the anterior chest lead, but they are concave upward. Most likely the changes in the myocardial infarction is concave, convex upward, but here it is concave upward. And sometimes there can be ST segment. There can be PR segment depression in some of the leads, which I am trying to see. Yeah, these are the. It is difficult to comment on whether ST segment is elevated or T wave or PR segment is depressed, but it is one of the ECGs indicating pericardial effusion or pericarditis, and typically you will, if you listen to the heart, you will see the pericardial rough, which is usually three component: the atrial systole, the ventricular systole, and ventricular diastole. So it will be basically. So this type of sound you will hear when you are auscultating the heart, and this is typical of pericarditis. Of course, the pain of the pericarditis is different from the ischemic origin. Yeah, this we were discussing, and I showed an ECG of the delta wave, which was not very clear last ECG, so I thought I would show you guys this one. So if you see here, the P wave is normal. Ideally speaking, this would have been the PR start of the QRS complex. The R wave would have been straight, and and the PR interval would have been from here up to here. But if you see, there's a initial slurring of the R wave, which you can easily pick it up. And because of that initial slurring, the PR interval is quite shortened. And of course, ST segment and T wave is normal. This is because of the presence of extra bundle between the atrium and ventricle, which is called bundle of Kent. And this is another example. This is the rhythm strip. You can easily pick it up now. The initial slurring of the QRS complex and the PR interval is shortened. So this is delta wave. And you will come across this ECG, every quite often. And these patients are normally present with supraventricular tachycardia or even fast ventricular rate atrial fibrillation as well. And you can see very easily, you can pick up the slurring of the R wave, which is delta wave. So this is WPW syndrome. This is another ECG, and you can easily pick up the slurring in the initial component of the QRS complex. Right, I have not shown you an ECG of the ventricular fibrillation. This is, very, very broad and very, very bizarre and unpredictable rhythm, and you simply cannot make out what is happening. So this is irregular, bizarre course QRS complexes, and this is ventricular fibrillation, and patient will be hemodynamically compromised, in shock. You will not be able to feel any pulse, and basically this is acute cardiac emergency. You need to defibrillate the patient then and there, and of course you need to look into how you are going to resuscitate the patient. airway breathing circulation, IV access, and of course, how you are going to proceed further. This is another ECG showing ventricular fibrillation, and you simply can't make out any of the QRS complex. They are changing. Every beat is different, and because they are chaotic activity and they are hardly able to produce any cardiac systole, so there will be no pulse. So this is pulseless, and patient will be in shock. This is another example of ventricular fibrillation. Again, another ECG showing ventricular fibrillation. Yeah, so various forms of ventricular fibrillation here. Just to show you and just try to complete as much as I can. So I think it should be more than that because I have another 50, 60 ECG, but that will take ages for me to finish it off. I think by finishing here, we will just call it a day. And if you guys have any question, feel free to call me now. And even if you want to get any explanation on any of the ECGs, any ECG confirmation which you may come across in your day-to-day practice, you can ask Dr. Abdullah to forward it to me, and I will just comment on that, and I'll be very happy to help you in any of ECG if you want me to do. Now I'm very happy to take a few questions if anybody has anything to or any comment on any of the ECGs we have discussed.
First, Doctor.
Sorry?
First, you are waiting that you join us in Telegram group.
Oh yeah, I forgot. I totally forgot about that actually. No, thank you for reminding me that. Actually, yeah. So
Oh, send the link again.
no, sure, I will do that. I will do that. Not tonight, but tomorrow I will look into that and I will do. Actually, I have never used Telegram before. I'm not very good in these newer things, but I will definitely do that. And of course, that will be a great thing for me to join you guys and of course to see what is going on. And anything else I can help you with this, with the any clinical topic, feel free to tell me or you can talk to Dr. Fahim and he can let me know. But now you have my direct number, so you can always talk to me. And any of the brothers and sisters or junior colleagues, if they need any help on any aspect, I will be very happy to help from here. And you can just coordinate with Dr. Abdullah and he can always talk to me. We have the contact details and inshallah everything will be fine in your future. Wish you all the best for all your future endeavors. And so any question today or nothing?
I think they have a lot of information now they need to process in the mind, then later maybe.
Yeah, so basically the important thing is, the the history taking is one of the most important of the clinical examination. First, take the history in depth, think about all the sinister feature, red flags, try to explore as much as you can from the patient. Then whatever information you have gathered in the history taking, just examine the patient in the light of that. Of course, there is no replacement, there is no substitute for the very good clinical examination. And just simply by history and clinical examination, you can get lots of information and you just need ancillary aid like ECG or blood test to support your diagnosis. As I mentioned, the Venki box, he was the cardiologist who was in France maybe around 150 years ago. That time the ECG machine was not there, but he simply felt the pulse of the patient and just had a look of the jugular venous wave pattern and picked up the Venki box phenomena or morbus type 1 AV block, which is marvelous. So you can do that. We are all capable of doing. We are a Muslim nation is a wonderful, very intelligent nation, but unfortunately, we forgot our golden era and we are not doing anything. So if we join hand, look after each other, help each other, inshallah, we will evolve and we will beat all these, people in Western world. Basically, we are capable of doing that, and we have shown that. We have done that. We have great physicians like Ibn Sina, Khwarizmi, so many, and basically they are the founders of the modern medicine. So
Yeah.
we can always do that again, actually. Yeah. So feel free uh, to ask anything if you want from me, and I will be there, inshallah, and I will join the Telegram as well.
Yeah, inshallah. One of the colleague, Noor Hamid, asked, can you please repeat how it's possible to distinguish that a patient had a previous MI?
Okay.
Explain.
Okay. Let me find out. Basically, if any patient is having uh, acute or fresh myocardial infarction, there will be either ST segment elevation, ST segment depression, and you need to have a look on the, basically ST segment is one of the very important nomenclature to differentiate between the old myocardial infarction and acute onset new myocardial infarction. So I'm just trying to go back and get the ECG of old and new myocardial infarction. So basically, if any patient is having acute onset myocardial infarction, there will be ST segment elevation or ST segment depression. And then over the course of time, when you started stabilizing the patient, the ST segment start going back to normal PR interval. There will be, it will come back to isoelectric or baseline. And over the course of few months, the T wave inversion will also go back to normal. So I'm just trying to find that ECG, one of these, I think it is this one. Not this one. Just give me so few seconds here. Right. So if you have a look here, this is the acute ST segment elevation myocardial infarction in the lead 2, 3, and AVF, which is inferior wall myocardial infarction. You can see there is Q wave already evolved, ST segment is elevated, Q wave is upright. While in the lead AVL, the ST segment is depressed and T wave is inverted. If you see this lead V1, V2, the anterior chest leads in lead 2, lead V2, V3, V4, V5, there is straightforward Q waves, and in the lead 2 and 3, the ST segment is still slightly upright, while in lead 3 there are T wave inversions. So once the ST segment is start to settle down and Q wave is fully evolved, the ST segment goes back to normal baseline or isoelectric line. And then this is the first thing over the settlement of the myocardial infarction. After the development of the Q wave, when the Q wave is fully developed, ST segment starts settling down to the baseline, and then T wave inversion will be there for several weeks or several months, and slowly and gradually it goes upright. So in the ST segment elevation or ST segment, non-ST segment elevation MI, the key is ST segment and T wave inversions. So when ST segment has come back to the baseline and T wave, which originally would be inverted, slowly and gradually go upright, that will be old interval in old myocardial infarction. Till the time the T wave is inverted, it is recent myocardial infarction. So this is the way we look into the age of the myocardial infarctions. And usually if the Q wave is there like in V lead 2 and 3, the Q wave is full blown and ST segment is upright and T wave is upright. So this is old myocardial infarction. While in the lateral leads, lead 4, 5, 6, you can see the T wave is still inverted. So this is recent myocardial infarction. And of course, in the lead inferior chest leads, ST segment elevation is there. Need not to say this is acute ST segment elevation MI. Hope that clears your query. And you want to clarify more, or it's hopeful? Is it clear? Is that okay?
Yes, inshallah. Thank you.
Excellent. Okay, wish you all the best, and inshallah, whenever you need me, we can always look into that. But I will join your group, and I will actively participate in that. So,
Thanks a lot, Dr. Ali. And inshallah, see you again. See you soon. All the
inshallah.
best. Please stay healthy and iltimas dua.
Yeah, same to all of you, inshallah.
Inshallah.
And fi amanillah.
Ya amanillah.